started with our session today. We are actually going to be talking about building bridges at the ED-ICU interface, specifically talking about models of care for the boarding critically ill patient. And this is going to be a very dynamic discussion. I have a wonderful panel of folks who are also going to be joining our discussion today. But very briefly, first our disclosures. This session is sponsored by the SAEM Critical Care Interest Group. Now, just if we think about our critically ill patients, the reality is that the demand is growing and there is a large volume of these patients that are coming through our emergency department. Looking at the National Hospital Ambulatory Medical Care Survey, from 2002 to 2009, we actually are seeing an almost 50% absolute increase in the number of ICU patients that are coming in through the ED. But the reality is that we have a growing number of patients, but a fixed number of ICU beds. So where do these patients go? Well, in the ED, they often have to board. Now, the classic approach to the ED-ICU interface focuses on resuscitation. But the reality is with the increased demand comes longer delays in getting that ICU bed. As such, ED docs are faced with providing more of the ongoing management previously under the auspices of inpatient intensivists. Now, we know that ICU boarding in the ED happens, but to what extent? Well, in a survey we did a few years ago, 72% of EM physicians reported regularly caring for boarding ICU patients. Now, some hospitals will say, well, that's okay. It's the general medicine patients who are boarding, and we really rush the ICU patients upstairs. But in looking at the National Hospital Ambulatory Medical Care Survey data, again from 2010, 30% of all ICU admissions boarded for greater than 2 hours. So this is not a problem that's going away. So is it time to consider alternative care models? Well, a lot of hospitals are already doing this. But what issues are they trying to solve with whatever care model they're really adopting? And in the same survey, we asked, well, what are the challenges with caring for ICU boarders? And pretty consistent, the top three were that they are seeing too high patient volume. Patients are still coming in through the ED, and they're having to take care of these ICU boarders, and it's really hard to do so. There's insufficient support staff. It's not that the ED docs don't know how to take care of these patients, but really that we don't have enough RTs or enough RNs who can really manage these patients in the same intensity, especially not the same 2-to-1 nursing that we have upstairs. And then finally, like the ongoing critical care interventions that are needed for some of these patients, that minute-to-minute titration, especially with all the influx of other patients coming in that are undifferentiated, it's very difficult to do so. Now, there was some difference between whether you came from a shop that was university versus community, but the challenges were pretty much identified to be about the same. Now, for today's discussion, what you see here is a conceptual framework of approaching care for patients at the ED-ICU interface. We expect that many institutions use variations or combinations of these models, and each personalized to their own needs and resource constraints. We're not advocating for one model over the other, although some of our panelists will be like, yay, Michigan. No. But we're not advocating for one, because one size doesn't fit all. But it should be readily apparent by the end of our discussion that there are common elements across all these models that really can optimize healthcare delivery for our critically ill patients. These are elements that are things like de-siloing, making sure we have really great communication. There should be no real downstairs, upstairs. There should be collaboration between specialties and increased awareness of the resource constraints associated with each setting, ED, ICU, PACU, whatever. So with that, our panel includes Dr. Wira, who's going to be presenting an ED-based model, an ICU and RRT model, that would be me, Dr. Mathews, the ED-ICU model presented by Dr. Gunnerson, and Dr. Aisiku, who will be doing the tele-ICU model, and then a triage resuscitation unit model with Dr. Menaker. Now, with that, I'm going to turn over to our fabulous moderator, Dr. Bassin, who will start us off.
Okay. Can you all hear me? Yeah. All right, so this is, again, kind of very free-flowing. So like Dr. Mathews said, any questions you all have, feel free to ask. We want to kind of incorporate those things. Yeah. So I actually work with Kyle in EC3 at Michigan, but I will stay neutral. So I think we want to hear everybody's perspective and see how the different models contrast and compare. So I think probably the best way to start is maybe just survey all the panelists for a minute or two and just talk about what your model looks like, how it functions, and some generalities, and then we'll get into some more specifics as the time allows.
Okay, so as you can see from the handout, yes, microphone. As you can see from the handout, I am the lone IM PCCM person up here. I am not clinical in the ED. In fact, I don't have an EM residency background, but I do research, obviously, between the ED and ICU interface. And I represent an ICU model where we deploy a team of intensivists to go downstairs and actually take care of the patients. And there is a formal handoff from the ED attending to us, and we take over the management of these patients. Now, this is actually functionally within the space of the ED, but with my team, I have me, I potentially have a fellow, I have nurse practitioners who help to manage these patients. Unfortunately, we're also covering other parts of the hospital. So there is the question of who's going to stay with that patient. So we rely actually on the RT potentially and the RN of the ED. But again, the decision making and the planning, the orders are all coming from our team. Now, this can take many different forms in different places. I mean, sometimes it's a deployed resuscitation team. Sometimes it's a rapid response team. It can be staffed by hospitalists, by intensivists. There's a lot of different forms to this. But the reality is it's a designated team without a space per se. It's using the space of the ED to care for these boarding patients. That way, the ED docs are actually free to take care of all the incoming patients. And that handoff is very smooth to us, who transition very well into the inpatient team. And we have motivation to get them upstairs as quickly as possible because we're spread not just in the ED, but also in other parts of the hospital while we're waiting for these patients to get ICU beds.
There's room in front. If anybody's in the back wants to come sit down, there's plenty of room.
Thanks, Kusum. My name is Kyle Gunnerson. I'm an EM intensivist at University of Michigan. The model that we have is a geographic ED-based ICU, meaning that we have 9 beds that are staffed and run within our emergency department, and we allocate resources to have that as an ICU caliber type area. Now, we are a closed unit, meaning that nobody else can write orders on our patients once we've actually, taken the patient on our service. We are a consult service, so the first couple hours that the patient presents to the ED in their shock state or during the resuscitation, our primary residency and primary ED team, they do the resuscitation, they do all the the fun procedures and things that need to be done for that first couple hours. If there are still ongoing critical care needs or it's very resource intense, that's when we're consulted. The same way as they'd be consulted primarily for an ICU upstairs. And then we would then geographically move that patient to our 9-bed ICU, which is right next door to our resuscitation base. And then we would be the team that's managing them from there on. Now, our team's composed of an attending that works a 12-hour shift and 2 out of 3 other providers, and those providers can either be PAs, residents, or critical care fellows. And we have a team that runs 24/7, so that staffing is on 24/7. Our nurse staffing is the same as an ICU, so we have 1 nurse per 2 beds at the very bare minimum. And sometimes that nurse can go up to the 1-to-1 if we need to, very similar to an ICU. Now, the training in order to round over in our ED-ICU or EC3 is either, of course, from an attending standpoint. If you're intensivist trained, you're qualified to round over there. However, it's not completely relegated to intensivists only. If you're not intensivist trained, as an attending standpoint, we put on a fundamentals of critical care support education class, multiple times a year, so our attendings can get that extra training. And then throughout the year, we have multiple CME and educational opportunities that keep everybody up to speed. That same type of training also is held for nurses. We do have some nurses who do have critical care backgrounds, but the majority of them are not. Every nurse, though, is as an ED-trained nurse. And so those nurses go through additional 2 months of orientation on critical care rotations upstairs for at least a month, and then the other month is now focused within our ED-ICU. All of the ED docs or all of the attendings that rotate or around over there, we're all ED attendings. There's no other job category, no anesthesiologists, no other, internal medicine or surgeons. We're all ED docs. We use evidence-based protocols. The vast majority of all of our patients get put into one or more evidence-based protocols that we've worked with collaboratively with inpatient services, such as the medical ICU, neurosurgery, or cardiovascular team. These protocols have been accepted, and we're up to about 15 or 17, protocols now. So there is buy-in from upstairs, and there is skin in the game, so to speak. One of the nice things that, at our model we think is the flexibility. Again, because we're ED run and we're staffed, when we do have times of capacity issues, when we may have available beds, but triage is getting killed and the main ED is, needing just help managing patients, since we are ED docs, we'll actually take patients back. We'll actually cherry pick a little bit. We'll take some patients back and we'll try and help, with the triage and the waiting room area to maintain the flow and the throughput within the ED. The keys are it's ED run, it's ED owned, it's within the ED, but it's a contained, self-run critical care service.
Great. My name is Imoigele Aisiku. I'm one of the faculty at Harvard Brigham and Women's Program, and my background is in different areas, both in medical critical care and neurocritical care, and I currently practice both in our medical ICU and our emergency department and serve as our EM critical care fellowship director. Independently, I have a significant amount of experience, exposure in the telemedicine world and do a significant amount of consulting in that arena. And so I'm going to focus more on talking to you all about that, considering telemedicine's exposure to emergency medicine is really sort of taken off. So frequently for our group, I'm the sort of consult person to how to integrate telemedicine into our EM practice. And so part of what I want to share with everybody here is that with the explosion of telemedicine or telehealth or what have you, and sort of not getting bogged down by the specifics of those definitions, and also what CMS views as telemedicine and what we view as telemedicine, there's a lot of subtleties and nuances to that. And so the amount of emails and requests I receive about how to implement it is rather large. And one of the first things I always have to explain to everyone that telemedicine is still medicine, and whether or not it should be implemented in your facility really becomes one of the first questions you have to answer for yourself. So there's a component of what telemedicine and ER, and you're starting to see a growing body of places or systems exploring tele-physician within their waiting rooms or things of that to improve throughput. But then there's tele-ICU, which has been established for over about 15 plus years now, and is now in some instances being employed in the ED model for tele-ICU or tele-critical care patients. And so you're sort of seeing this evolution of bringing in those components to it. The advantage of doing a telemedicine, if you just talk about the care perspective, there's a significant amount of technology implementation, cost aspects of it. The telemedicine platform allows for a significant amount of mobility when implemented in a particular way. And the reason being is the platform that you can use. So you've got that, imagine in our ED, for example, we have 4 different pods, and you don't have the luxury of taking a critically ill patient from all of those pods and then coalescing them in one area. And so if you're asked to consult, you have to consult in all 4 different pods, and that can be a little challenging. And so the ability for the tele-practitioner to be able to go to them via technology makes it a much physically easier way to toggle between sick patients in between. Your ability to interface the vitals and changes with you in one area and the patients in 4 different parts of the ED changes. The instances where you as the ED physician now has a cardiac arrest patient that you know is going into the ICU, but still has multiple instances of hemodynamic compromise, and you now spend the next 2 hours of your day resuscitating that, and your waiting room unfortunately doesn't have that information, so it keeps coming in anyway. Your ability to turn that over and allow a significant amount of management. So the constructs on the technology side allow for ultrasound connection, a variety of what we call peripherals that really augment your ability to provide the look and listen aspects of your traditional care without the feel component of it. And so you may rely on your ED physician or residents, depending if you're in a community or academic model, to, does that patient need a line? Yes. You can actually help the any designated person actually do the intubation, and then you can manage, do physician, computerized physician order entry, all of those aspects of it that really can help from a provider perspective, expertise perspective. And so the concept of the tele-ICU is well established. Bringing it to the ED becomes the next phase, and how do you do that? And how do you make it, and make no mistakes about it, this is disruptive technology. How do you bring this disruptive technology to an environment that's already disruptive, and make it work for you? And I think that's the part where, I found a lot of fun in doing this. And once you understand the technology piece, once you understand the care delivery issues, the real next step is understand what's the problem you want to fix. And it really allows you a significant amount of flexibility to create a platform that may work for you if you choose to go down that path.
My name is Jay Menaker. I am an emergency medicine surgical critical care trained physician. I work at the University of Maryland Medical Center in Baltimore. And I work in what we call the CCRU, which is a critical care resuscitation unit. And a little unique to the other models here, our unit actually is in the Shock Trauma Center Critical Care Tower, so it is totally separate from the University of Maryland Medical Center's emergency department. The original design of the CCRU was really to bring critically ill patients into the medical center from outside outlying hospitals, predominantly from emergency departments, but also some inpatients as well. The reason for this was a couple-fold. We wanted to have the thought of always having an available bed. So as where the inpatient ICUs may not have a readily available bed, the goal of the CCRU was to always say yes to try to minimize transport times for these critically ill patients. The other goal was to really get the right patient to the right place at the right time. We were finding that a number of patients were coming into specialized ICUs that were really not really where they needed to be. So they would come into the CCRU, we would evaluate them and get them and decide sort of what they needed acutely and get them to the right place. The CCRU is set up in that it is an attending mid-level predominantly run unit, so 24/7 there's an attending physician who are all critical care trained, predominantly emergency medicine, but there are surgical, pulmonary, and actually we had a family medicine critical care trained physician as well, along with nurse practitioners and physician assistants. So as I said, that is 24/7. And the process essentially works that the outside hospitals consult a specific service, whether that is a surgical service or a medical service, and on a line with all of us on the phone at the same time, we can all hear the patient, figure out what they need, and we bring them into the CCRU. The goal is really to have them there really only 6 hours. As we say, when the CCRU works really well, it works really well. We can get the aortic dissection in a few minutes, and they're off to the operating room in a few minutes. We can get the acute stroke into the hospital to CT scan, into IR in a relatively short period of time. The other things that we can do is sometimes when patients, as I said, are described as one thing and they need something else. We recently had a patient who was really needed a MICU for a calcium channel overdose, but ended up on VA ECMO as well as Mars therapy. So that patient obviously did not go to the medical ICU. So that was the original goal of establishing the CCRU. What happened subsequently is these other models are finding out is that we then became sort of when patients decompensated within the medical center, there weren't readily available ICU beds. So the CCRU, with the goal of always having a readily bed, they would come to the CCRU while the inpatient ICUs would make an available bed. The other thing that we were finding is, critically ill patients in the emergency department that would burden their resources, sort of as these other models have, we became sort of that extension of the ED in patients that really burden their resources. So although we really were initially designed to do one thing, we've sort of expanded into 2 or 3 other goals as well. So that's really, as I said, so we're really a little, our initial goal was to be a little different, but we sort of ended up to be very similar, although we are located outside the emergency department.
Thanks. And I'm Chaz Wira. I am the opposite bookend of Dr. Mathews, the pure EM model. And background about myself, I did EM training at Henry Ford, overlapped with Kyle there. I also, in addition to working in the emergency department, take call for the stroke service probably 4 to 5 times per month. And at Yale, just so you understand our infrastructure, because different EDs have different infrastructures, we have 3 different sections of our ED. We have an A side, which is the higher acuity area, which is called major med, and that's where all of our critical care patients go. So we don't necessarily have a pod system where a team could be managing a cardiac arrest and then getting a patient with strep pharyngitis. We have our critically ill patients cohorted to the same area. And our critical care area has 19 beds, 4 resuscitation rooms. It is staffed from, depending upon the time of day, by 1 to 2 attendings and 2 to 5 residents. And our nursing ratio is roughly 4 to 1 for management. The model that we have, when patients are in our emergency department, we are the primary providers for them, and certainly we do collaborate extensively with our critical care colleagues for the management of patients. We have protocolized care for some responses, so for instance, stroke responses, TTM alert responses, get automated consults for cardiac arrest survivors. But for the most part, regardless of the duration of time that the patients are in our unit, we are the principal providers. And then in cases of extended length of stay, we correspond with our ICU colleagues on a consultant basis. But we're the ones who do the procedures, put the orders in, redose antibiotics, and basically oversee the entire care. It is when consultations occur in extreme time periods of surge, we have modified over the course of the past 10 years to kind of a shared responsibility, but still the procedures and the orders still fall on our shoulders because our ICU teams really don't have the resources to dispatch an extra attending or dispatch a team, for that matter, to the ED to be able to manage patients. So that's kind of our system, and we can talk more as questions arise.
Good. Okay. So that's a good overview of a number of different models, and they all have a little bit of different approach. Just a quick poll of the room. How many people experience boarding of critical patients in their EDs at their institutions? Good. So almost everybody. And then range of time that you might experience somebody boarding. How many board just on the aspect of hours? 1 to 2 hours. What about kind of upwards of 4 to 6 hours? What about greater than kind of 6 to 12 hours? Anybody over 24? Okay. Wow. Okay. So at different gradients, but really a problem for almost everybody, regardless of where you work. So I thought maybe we'd talk just a little bit about how you manage the transitions. The transitions with every model are a little bit different. So these are critically ill patients. They're boarding. Obviously, these are resources that are available to manage these patients. And how do you manage the transition of care, of who's managing the patient, who's delivering the care? How do you manage quality and safety of these critically ill patients as you're kind of integrating these hybrid models of care in different environments? Some are geographically in the ED, some are inpatient models, some are response teams, and some are hybrid models. And how do you manage these transitions of critically ill patients across teams?
So I'm just going to start. One of the things that the reason why this model developed and has been successfully deployed in one of our sister hospitals is because it met a real need that there were just prolonged periods of time where patients were not getting as active of critical care that they should be getting. And it was no fault of the ED just because of sheer volume. And to minimize the number of care transitions, the number of handoffs that were happening, it was deemed that the ICU team coming downstairs as a mobile unit helped to make a more seamless transition from downstairs to upstairs. And that allowed for things like, getting people on the right vent settings, getting them on the right sedation targets, and various other things that I'm sure Kyle's going to say the same thing about EC3 able to do, because they're getting critical care regardless of location in the same level and intensity that they would get in a 2-to-1 nursing ratio upstairs. Now, unfortunately, with the ICU model, we are a bit constrained in that I don't have my own nurses. I have a nurse practitioner who can help guide things and help write orders. I will have a respiratory therapist potentially with me to help with some initial management, but we have to go and be deployed to other parts of the hospital as well. Sometimes I can leave somebody with them, but they're constantly checking in, but the burden is still on the nurse to call us or called the ED if we're not physically there. So that is one of the drawbacks to an ICU-based model when the primary team who's now taking care of the patient is not physically with them. So we do have this challenge with safety and quality from that perspective.
And what about the timing as well? What time? And I know it changes, but on average, where do you get involved in the care of the patient?
So the ED, however long it takes them to resuscitate the patient, will call an ICU consult, and that consult is done within 30 minutes, and a decision is made. That patient goes for ICU, the request for admission is made, and in the models where the ICU team goes down or critical care folks go down, it ends up being, I would say, within 2 hours of their ED arrival, and then hopefully they get upstairs very quickly, because again, we don't have any incentive to keep them downstairs. We want them upstairs as quickly as possible.
Okay.
I mean, again, it flexes depending on the volume of patients, and sometimes they have to stay downstairs longer, but the ED is very good about being able to recognize how, like, this is a critically ill patient that needs an ICU, and activates this kind of model to help take care of these patients.
Great. Kyle?
So in our ED-based ICU model, or EC3, we have flexibility, but the idea, the averages are the EC3 team, the critical care team that's based in the ED, gets involved roughly within 90 minutes to 2 hours of the patient presenting with an acute critical decompensation, and that's our initial consult from the primary ED team. The second time frame that we look for, remember now, we are not under the same time constraints and pressures as the main ED, so disposition for us is not as pressing right away. We're more of a treatment and diagnosis appropriate treatment unit, unlike, sometimes we just don't have the ability to do that to the extent that we'd like to in the main ED when you're, sitting on surge capacity constraints sometime. So the next phase then we manage these patients. We're looking at probably about 6 hours if they're still really critically ill. That at that time we'll get the medical ICU team down just for a touch base, looking at how many beds they have upstairs. A lot of times we'll batch, and so we'll round with a medical ICU fellow on several patients down on our EC3 and kind of look at what resources we have available for the rest of the shift. Now the next phase for that, we are actually able to then, for a vast majority of our patients, downgrade them. We only admit about 30% of our patients to the ICU. We're able to downgrade roughly around 50% or more of our patients from at least a one-time critical care status to now to where they can go to the floor or even go home for that matter. And so, by doing this, having this time, we're able to then, decrease our ICU resources, again, when we're faced with, the time to do this. And so the time to where we'd actually then try and get them to their inpatient disposition is roughly around 12 hours or it's up to around 10 to 12 hours for ICU patients, and about 15 to 16 hours for our floor patients. And that's also dependent on boarding status and inpatient bed availability, which they board about 5 hours on an inpatient service if we can downgrade them. But that's roughly the time frame that we have.
So I will say that one of the things that's pretty remarkable is that you're able to downgrade, because the key thing is that you get them upstairs to the ICU bed, and it takes them so long to get them a floor bed from there. So to downgrade them once they're already in the ICU, that ICU boarding period is actually quite prolonged as well and ties up beds. So you're actually alleviating it from the front end.
So I'm going to be the Star Trek person of the group here and say that all of the solutions that we're discussing to some extent have the benefit of at least an experimented try platform to work on. And I'm going to challenge everyone in the group to think of a very novel way to bring this technology to your patients. To give you an ordinance of scale, in an EICU model where you have one physician and one nurse practitioner and one secretary assistant individual, 70 to 100 patients can be seen in that system. And part of the advantage of this is you integrate your monitoring system into your platform. Now, we all talk about how, yes, we have a patient in the ICU, but we have some that are walking and talking and sitting in the ICU, and some that are in full-blown ARDS on multiple presses and what have you. And so the concept of taking the data and having it pushed to you, right? So there's push-pull components to how your data stream as well, so that I see all the vitals, put them together, and create which are the sickest patients. So those 70 patients, there's going to be 15, 20% that are critically ill, and you're going to have 15, 20% of them that really you can have your nurse practitioner, somebody else really continue to help with those patients, for example, and you focus on those particular patients. Now, take that scenario, and 7 different hospitals is where we did this with one of them being in Alaska. All right, so whether you're in 1 pod or 6 pods or what have you, we're going to break down those barriers as well. And then, as well stated with the different evidence-based protocols, we now invoke or overlay decision support components to it. So if you see a lot of the sepsis data that's coming out about how you can set alert triggers to, does this patient meet sepsis criteria? Now, I don't know about you all, but in our OBS units where we have some responsibility or patient boards, one of the sort of the challenges is you go through how many physicians when that patient boards 6 hours, 12 hours, or what have you. And I assure you, those number of physicians that go through, a little bit of information is lost along the way. Embedding some of these in there allows you to place these evidence-based protocols and give push feedback back to saying, this was the diagnosis, this is the protocol, is it time to give this medication, is it time to do this? That actually, these are things that while exist in the tele-ICU world, may not be in the tele-ICU ED side of the fence. And so while it's novel technology, it's novel outside of the ED. The question is, how do you bring all of those to here? So sort of saying challenging to break the physical barriers we have. And if your resource is physician, if your resource is data, if your resource is space, here's a way to potentially manage that. So trying to put some concrete numbers of actual situations that I've practiced in, worked with other colleagues in, and seeing how we've been able to manage some of this.
In terms of minimizing handoffs and information switching, you know, the physician is on the call from the start, so we have that information. The nurses get report. The physician then gets a call back once the transport team is on their way. So by the time the patient gets there, we are able to have up-to-date minute on the accuracy of what that patient's current status is. So what trips they're on, so we can have all that pre-ordered, pre-ready for them to be there. Additionally, we can give the primary team, especially if it's a surgical team, a heads up, so they sort of know the patient's going to be there in 20 minutes. And this plays key when patients need an operation because the operating room is already ready. So we've set it up that this transfer of information, although may seem a little redundant and overburdensome, really allows us to be as prepared as possible. And for the patients that come and that we do stuff for, we transfer information directly to their next ICU bed. So it is not sort of whispered down the lane. It's they come in, and then we give bedside report to the people that are going to be taking care of them long term. And in terms of measuring the quality of what we're doing, it's a little challenging because we're sort of a multidisciplinary unit. But what we've been trying to do is to show that you're bringing the patients into us as opposed to a dedicated ICU, that our patient outcomes are the same. And I'll give you an example. You know, the stroke patients that come in, whether they land in the emergency department or they land in the neurocritical care unit or in our unit, the CCRU, that the outcomes are the same for those patients. And that's really what is important to us, because what we want to make sure is that we're at least providing the same care regardless of where they land in the institution. So those are some of the metrics that we're trying to show, or at least to reach, because if we're not providing the same care, then to some degree we are defeating the purpose despite bringing in more patients for the medical center.
Jay, can I ask a quick question? Have you guys, you had mentioned earlier that you also take patients who are decompensating in the floor, patients who are resource intense in the ED. You guys looked at whether or not your model helps to alleviate or improve the outcomes of those patients as opposed to leaving them wherever they are?
One of my colleagues is actually looking at that data. I don't have that information, but we are looking at that to see if those patients, and it's a little hard you have to start going back to historical data, which is a little hard to compare, but we are trying to look to the patients that, and we use the term rescue for lack of a better word, but predominantly the ones from the emergency department, the ones that do have some predefined requirements to be transferred for us, whether it's high vent settings, multiple vasoactives, needing massive transfusion, intracranial monitoring, things that would be resource intensive for the ED staff that we will bring up to us. So we are trying to see whether those patients are either doing as well or better than historical cohorts.
Jazz, why don't you give us a few comments, and then I just want to leave the last few minutes for questions for anybody.
Yeah, sure. So a quote first and foremost kind of comes to mind when we look at all the different systems. The late Peter Saffer at Pittsburgh said that critical care is not necessarily a geographic location, but is a philosophy. And what you can hear from a lot of my colleagues up here is that, depending upon the differences in the systems, the resources, the resource allocations, the staffing, the personnel, depending upon what your individual hospital may have, there's different, items on the menu that may work better for your system. Getting back to like transitions of care and in particular, too, I can talk about a little bit the evolution of care that we've had at Yale. First, when I came to Yale 14 years ago, in the overnights, we actually had no fellow or no in-house intensivist coverage for our medical ICU. And I'm curious, how many people in the audience still have a model that's like that? So some, and certainly things are changing and evolving. And, when comparing a past sepsis registry to a more modern day septic shock registry, we saw that mortality rates were 41% back in the older model, 29% in the newer model. So certainly from an EM perspective, having the aid, assistance, and resources of intensivist coverage, intensivist knowledge, intensivist ability to be at the bedside for enormously complicated patients, whether it's a multi-vasopressor dependent shock patient or a complicated asthmatic patient with peak airway pressures pushing 50 or 60. Having the resources in the hospital is first and foremost, from a patient-centered sense and a patient safety sense, an ideal thing. In terms of our model and how we work transitions, one thing, two of our EM intensivists are actually in the audience, and one, John Sather, is kind of the architect of this process, but when we do have, for background information, we disseminated to our faculty with our MICU director signing off on it, predefined ICU admission criteria, step-down unit admission criteria, and then higher acuity patients who can go to the floor, for instance, DKA patients who don't have severe acidoses. So we have that for background information. Another thing that's been promulgated is that when admissions are made, we have an attending-to-attending communication about the case. And for background information, I think it's a wonderful educational opportunity for our faculty group or fellows who are making the calls. And there's enough latitude in the system that, again, like I said, if it's an extremely complicated patient, we have some cases where the intensivist is downstairs within 2 minutes kind of helping out, setting the ventilator settings or helping to manage a more complicated patient. So lines of communication, enormously important. The third thing, too, is in times of surge, we have found that our system has been adaptable. We have had, kind of following my panel partners' lead, we do have 2 tele-ICU beds that have been utilized in times of surge. These are exceptional time periods when we've had vasopressor-dependent patients in our ED for up to 23 hours. And we have at times instituted arrangements where the ICU rounds are predefined time periods with our ED team. And again, that's a wonderful thing from a patient safety perspective, handoff perspective, but also an educational perspective, for our faculty, fellows, and most importantly, residents and students as well. So our system has kind of, it flexes a little bit when our population expands and our length of stays extend to 23 hours, as opposed to, say, the average of probably 3 to 4 hours for septic shock patients being a population that we looked at. But the adaptive design is, I think, something that kind of figures into it as well, so we can try to uphold Peter Saffer's quote.
Great. Any questions? Anything they want to ask? Yeah, please. Use a microphone. Yeah, you can.
This question's for Dr. Gunnerson. So for the ICU patients, or for the patients who meet ICU level of care, when you make the decision to admit that patient and there are inpatient ICU beds available, how do you make the decision to admit that patient to the ED-ICU, and when do you admit those patients directly to an inpatient ICU bed?
Right. So that's a good question. On a medical side, we want our spirit of EC3 and for the ED is for all medical ICU consults or admissions to go through EC3. And the reason being is that there's no surgical or specialty type service that the medical ICU can provide. Sorry, such as a ventric or a balloon pump, or something like that. You know, maybe they can come down and do their lung cancer biopsy in the ER or something. So, but the other thing is that these patients are a lot of times can easily be turned around within a little bit extra, time. A COPD exacerbation on non-invasive positive pressure ventilation, or maybe septic patient that may need just a little bit more fluid and some, volume assessment. And those patients, depending on, how they're looking, we can, even though there may be some beds available, we can actually downgrade the vast majority of those patients to floor status. Now, if there is a very sick patient on multiple pressors, really sick, we want to make sure, we'll take that extra time and just to make sure we didn't miss anything. Or do they have ARDS because they have ischemic bowel that was missed because, they thought that was just a pneumonia. Well, it turns out they have dead gut and they need to go to a surgical service. That, we find that sometimes. We want to make sure our diagnosis is, is spot on and that, we don't have any surprises upstairs. In those cases, we'll, maybe do some extra studies, maybe do an extra line or procedure, and then we'll get them upstairs. We won't try and turn, or hope that those patients will go to the floor or even go home in those cases.
I will say that in the literature, we are notoriously bad at predicting like how long patients are going to need ICU level care. So it makes sense that if you can have the resources to have this extra unit to basically do that extra few hours of triage to figure out like how sick are they going to really be and whether there is going to be a quick turnaround. But even then you don't really know for sure. This is an extra unit, an extra set of beds that we have sort of like to deal with the gray area patients. If your unit has a really no problem with getting the ICU patients who once they're ward ready to get them out the door, then it's perhaps less of an issue to even send the lower acuity patients who are quick turnaround to an ICU because they won't actually take up that much time in the unit. It just really depends on your institution and how efficient is the patient flow.
And from a time frame, we usually try and look at 6 hours. So after about 6 hours, plus or minus an hour or so, we'll get the ICU fellow down just from educational purposes as well as triaging. And if there's 4 beds available and this patient hasn't moved much, we'll just send them upstairs.
Any other questions? Yeah.
Do you ever send patients that are kind of like notorious people that come back recurrently for DKA like directly to your unit to like skip the ED part if they like? I mean, we have like maybe 5 or 6 patients that are just there every week multiple times for DKA, and I feel like you could send them home in 6 hours probably.
I'm assuming this is for me.
Yeah, just be sorry.
Okay.
Yeah.
So DKA is one of our success stories. The emergency department always does a really good job with DKA, and we do have our patient actually comes in multiple times a week. But we've also found with DKA, rarely, I mean, it's really rare that we'll have to admit somebody to an ICU. The majority, I'd probably say over half of them, we can actually turn around and they can go home. A smaller subset will actually need to admit them. So an example, we'll have somebody comes in with pH of 6.8, have a huge gap, and we'll put them within our protocol, and they'll spend the night with us. In the morning, they'll be eating a full diet. They'll be getting their insulin. We'll have their endocrinologist, will come down or a consult or just talk to them on the phone for that matter, and we'll be able to send them home. It's gotten to the point now to where our fellowship director for endocrinology has asked us to consult them on their patients because they're not seeing DKA and on the inpatient. You can imagine graduating from a Michigan endocrinology fellowship without seeing DKA may be a problem. So we actually had a lot of success with our DKA patients.
And I think that's a patient population that can be managed in some of these other models as well, right? Pretty effectively. I would think Imo or Chaz, that's a potential model. I mean, the DKA can be managed in these other models as well as kind of a disease process that lends itself well to multiple modalities.
So, quick question. My name is Lance Becker from New York. And my question is, has the ED-ICU interface had a positive or sort of negative effect in allowing critical care as a specialty to reduce its variation in care. And so I know, like, I'll just speak for like my institution, but I have like one unit that will treat a patient in a certain way, and if that same patient turns up in the next unit, like, that patient will be treated quite differently. And so we kind of know that variation in care is probably a signal that maybe we should do something a little bit better, a little bit differently. And so I'm just wondering, particularly with the telepresence potentially, with the ED-ICU, has that allowed us to reduce our variation between some of the units, to maybe increase dialogue between units and to actually improve critical care for all patients?
That's a really great question. You know, I was recently communicating with the tele-ICU director at Inova's system, for example, and they've over the years, and they've had probably one of the more established, robust tele-ICU systems, and at least anecdotally they feel they have. But one of the things they've done is the majority of their ICUs are under a tele-ICU model, and so it's all, for example, whether it's in a medical or surgical patient, we'll speak about it from a patient perspective, they have them under the same sort of model, so the ability to institute the protocols and so forth, they have much more control over that variation. As long as you're separating the units, then I think you're going to have a hard time doing that irrespective of the models that we have. So if the same patient goes to the CCU one day and then goes to the MICU the next day, or one caregiver from either one, that you're going to find that variability outside of physician-related variability. But one of the reported favorable things that they found out of it was they developed a model where they could consistently train a larger group of physicians to have more similarity in their practice pattern. And then in these models, they have in-house ICU attendings as well, where the amount of discussion, communication, and agreement on the protocols also became much more in agreement across the different platforms.
So Lance, one of the other things that I know you know very well is that the reason why we have such a problem with ED boarding is because we need our patient to go to a specific unit, right? It's not that you're saying your hospital has 100 ICU beds, that patient can go to one of the 100, it's that they can go to one out of the 14 MICU beds, you know, and they are either deprioritized or whatever for the other beds. And in some of the literature actually supports that they may be getting better care in their target unit. But things like tele-ICU or even improved communication between ICUs, so de-siloing from that level, as well as de-siloing and understanding that the ED is providing critical care and we should all be providing the same kind of critical care. These shared protocols, these shared guidelines allow for that unification of care and standardization. And don't get me wrong, there's stylistic practice differences, right? I will manage like certain disease processes one way, another person might manage them differently, but everyone should manage early ARDS the same. You know, I think we have enough evidence now, but we don't.
Yeah, and as far as the EC3, we have multiple care pathways now that have, and protocols that have been accepted through all of our ICUs. And so it's not so much, I'm not sure exactly how it's going to differ once they get upstairs, but I can tell you we have care sets for how do we manage subarachnoid. We can implement those quicker. We can achieve goals faster than we did before, more accurately, and even better yet, now we're able to measure them. We're actually able to keep track of them. Whereas before, you know, whether or not, you know, the timing to blood pressure control or things like that, you know, the Q1 hour neurochecks, whether or not we're able to meet them, we just didn't know. Now we're actually measuring and we can actually follow up on this.
The same thing in the CCRU. We've actually spent a moderate amount of time with a bunch of the services to make sure that the care that we're providing is actually standard throughout the hospital. So subarachnoid, strokes, type E dissections, things of that nature. We've sort of gotten everybody, whether it's the ED, the CCRU, cardiac surgery VADs. We've all come to the table and we have algorithms that we all follow. And there's a little variability, but we have structured guidelines that so everybody's doing the same thing regardless of where they are.
Yeah. Well, I think we're just about out of time. So one, I want to thank all of our panelists for participating.
So just in the last minute, I do want to say a couple of things. So we talk about how we're going to improve care at the ED-ICU interface. And I love that Dr. Becker actually ended with this question, because I think this is the primary reason why we are interested in finding out which care model works for our institution and figure out how to move forward. And so I hope, like, we talked a little bit about this, but really it's something that I want to convey to all of you. As you're figuring out what to do in your institution, you should be conducting process mapping. So figure out the elements to understand your operations of ICU triage and boarding in your ED. Look at your numbers, your data. And then collaborate. I mean, that's really important to identify healthcare delivery objectives that delineate shared metrics for smooth operations. Maybe you want to reduce ED length of stay. Maybe you want to take in more outside hospital transfers. Maybe you just want to improve how much ICU bed availability you have in times of surge. This will involve de-siloing, improving flow, increasing flexibility, and again, having shared expectations of, is the ED responsible for putting that line in or tubing that patient, or is it the ICU's job to do it once they get upstairs? And then I keep saying this every time I give this, sort of talk about this, is that we really need to have joint evaluation. So we actually know, are we impacting patient care? So if you're going to be implementing any of these care models, just think about what you're going to measure. And I love that Dr. Bassin started with that question at the very beginning. How are we measuring patient safety and quality when it comes to this very vulnerable patient population at this critical time? So what's next? I mean, there's been a lot of talk about workforce expansion, training up more EM folks to actually become, EM intensivists and actually staff these newer models or existing models, or bridging both the ED and the ICU and really being able to bring these two worlds together. And this addresses the intensivist shortage that we're seeing, right? But I actually think that this is a way forward to actually improve the care of our patients in our ED. But we have to think also about RNs and RTs and other ancillary staff that actually play a key role. Are they unionized? How many patients can they take? How flexible can they be? I also think we need to be thinking about an ICU without walls. It doesn't matter where they are. They should be able to get the services they need. And I would be remiss, and this is because I'm a researcher, to think about the quality improvement research opportunities that we have. We have process and outcome metrics that we can look at. We can look at our systems of care, and we can also measure things like collaboration and communication. So with that, I will say thank you. The panelists will be here for a little bit, but here's a quick plug. At 3 o'clock, we're having our critical care medicine interest group meeting upstairs on the 3rd floor. There will be a panel including Dr. Gunnerson, Dr. Aisiku, and Dr. Menaker to talk about career opportunities and things like this at the ED-ICU interface as well. So I hope you guys can all join us. Again, thank you so much.